Like, I am over this, what's going on here? And I seriously thought I had all your stuff done.
Yeah, no, give me some documentation.
Okay.
All right, so, did you text them?
No, I just checked to see if they did anything, but I'll ask them when they are, I guess.
Okay, thank you. And I just now started recording, so they're gonna miss the first half hour. So record retentions, we have to store documentation for an established period of time. Medicare says we have to retain our patient records for at least 5 years, or whatever the state says, whichever is the longest. So if the state requires 10 years, you always go by the strictest law. That's the same in pharmacy as well. So whichever the strictest law is the law you have to follow. So Medicare says you have to retain patient records 5 years, but if the state says 7, then you have to maintain them for 7 years. And this made a lot of sense when we had paper charts, right? Now that we're electronic, do you feel like, I mean, I don't feel like storage is a problem. There should be no reason to destroy a patient's chart after 5 years, because storing data in the cloud, whatever the heck that is not, it doesn't take up physical space. Whereas with paper records, we had physical space. And I do know a lot of physicians who will never destroy their patient records. So if you were a patient 20 years ago, they still have your record from 20 years ago, just because of the paranoia of getting sued. We talked about individual state laws, so you have to follow the strictest law.
So if they have like a policy for destroying records after a certain amount of time for some reason, then can someone sue them for not having it?
No, not as long as they're following the law.
Okay.
How would you go about suing any healthcare professional though? I mean, like, how could you sue a hospital? Like, would you just like hire an attorney and be like, I feel like this was malpractice and this is why?
Yep.
And they'd be like, okay.
They would review the information and decide whether or not you have a case before they would take it. Or a reputable attorney will review it before they decide to take it.
I'm gonna probably use the wrong terminology. Is there like a statute of limitation for when you can like?
I believe so, but I don't know what that statute is. And I think I believe it depends on the allegation as well.
It's always by county, right? The statute of limitations, things like that.
No, not always. It depends on what the allegations are. I mean, if it's something that was life-altering, like they cut off the wrong leg, although you would know that immediately when you woke up, that lawsuit would be like this.
Yeah, right.
But
they'd be like, so here's the paperwork for you to start your lawsuit.
Right. Wouldn't it though? And sadly, it doesn't happen a lot anymore, but it has happened enough that there are policies and procedures in place to prevent that from happening. Yeah. Yeah. I don't even know what to say. I mean, if you're getting, I suppose if there was no outward reason for amputation, but like if I've mangled my foot and you cut off the wrong one, then whatever, you're dumb and you should get sued. But I have never understood wrong side amputations, but it happens often enough that we have policies for that and policies to prevent that happening. So.
What kind of policies? Like marking it or something?
Yep. Yeah. Marking the limb to remove and marking the limb to not remove. They have special
cover, don't cover.
Yeah, they have special markers that you use, skin safe markers that you use to mark the limb with, and yeah.
That's sad.
Yeah.
That just sucks. I feel bad for those people.
Talk about life altering.
Seriously. You're prepared for only one foot, not both.
Yeah, and then they end up a double amputee.
Yeah.
Yeah.
I have a really weird question, and I'm gonna sound super, super dumb when I say this, so please just bear with me.
You bet.
Went to Target the other day. I don't go there ever. There was this lady that went in and she didn't have feet. But she was walking, she had cups on her feet, and that's why I said I'm gonna sound really dumb. They weren't cups though, like they were obviously a medical thing. They were cups. Do you have any idea what they were? They looked like cups though.
Was it the sleeve that they put on?
I don't know.
So sometimes they have a neoprene sleeve to protect their stump with. So they put on this neoprene sleeve and then they have like a plastic cup. It looks like a cup.
Yeah.
Yeah, like a plastic or fiberglass thing that goes over the sleeve that they could then attach their prosthetic to.
It didn't have a prosthetic on it though. It was just a cup.
Maybe she's
Amazing.
getting more prosthetics, or
Like,
maybe she doesn't want prosthetics.
I don't know, but like I just thought it was like the coolest thing ever. I was like, you have like amazing balance and you should be an acrobat. I didn't say that to her obviously because that would have been really inappropriate.
Right. Yeah,
I was
from
just
what
like-
you're saying with the cups, it sounds like she had, the part that would attach to the prosthetic on. And
Okay.
it may be that they're making her prosthetics or that they're bothering her, so she was wearing those as protection for her stump until her
Well, and
prosthetics.
she really didn't have like any square crutches or anything. That's why I'm like, she was like,
Or maybe she just hates her prosthetics.
she just was like super balanced. And I was like, you're an amazing person. I obviously didn't say that either. I just like pretended like I didn't notice and just walked away. But it was cool and it's like really stuck with me. I haven't asked anybody and I meant to ask Nate, but the conversation never came up, kind of talking about cutting people's legs off. So I'm just kidding.
Okay, so glad I could help. Whew, okay.
Sorry.
So HIPAA requires that we retain health insurance claims for 6 years unless the state law says more. So we always follow the strictest law. And for 2 years after a patient's death. So that would be, with a patient's death, that would be your statute of limitations is 2 years, because after that, then they can destroy the records. Okay. But yeah, each thing has its own. Depends on how egregious, I can't say that, egregious it is. I can spell it, I can't say it. Well, hello there.
I am so sorry.
We were missing you.
See, okay, I have a long story. So, I had an appointment at Concord Dental at 7 a.m.
Mm-hmm.
Everything's good. My mom offered to take my daughter to my babysitter. She takes her until 8. I was like, okay, from at a dentist, I'll still make it because I'm going to visit.
Right.
Then I get a call, like, as I'm already on my way over here, almost in Windsor. And she was like, somebody hit me. A semi rear-ended her.
Oh my God, is she okay?
And, like, it was like through the side because like the semi was really distracted, and when he tried to stop, he tried to swerve to the side. So he still hit
Sideswiped her.
And she's on my insurance because she doesn't have a driver's license, so the truck's under my name and everything. So she's like, I need you to come back because I don't have a driver's license. It's under your insurance, and the cops are trying to speak. They think it's not my truck and stuff like that. So then I had to go over there, and then. So then we did the report, and then I had to take my daughter to the babysitter, and then my mom to work, and then she couldn't drive the truck anymore because she was under her name. So then we were waiting for my sister to leave school and come pick up the truck because she has a driver's license, and then.
Is everyone okay?
Yeah, she's fine. And
That
then
would be the
and then I
scariest
forgot
call
to leave-
ever,
and
a
then I
semi
forgot
hit
to
me.
leave the car seat for my mom
Uh-huh.
in the morning. So then the cop was like, you're just good in the morning, but your daughter needs to be in a car seat. I was like, I know that, and I forgot to leave the car seat in the morning, but
Okay, well, happy Monday on a Tuesday.
yeah,
Dang,
it's been a while.
bless you. Well, I'm glad you made it, and I'm glad your mom and your daughter are okay.
Yeah, they're fine.
'Cause that's some scary
she was
stuff.
just kind of scary,
Okay, well,
I was like, well,
that makes me being cranky about having to wear grown-up clothes and seem nothing, huh?
why are you wearing
Because
clothes?
they're making us take pictures.
Oh, gross.
Yeah, I hate pictures. Yes, thank you. That was my response. I looked at the calendar today and I was like,
I
oh.
cried every time someone take pictures. There's a lot of pictures of me falling next to my sister and stuff. Like, why?
I'm afraid that if they do that, they'll make me take them again. So no crying when I get my picture taken. We just did this last year too. I said, can we use those? He said no.
Kayla said she's not feeling very well, and I said she's on Zoom. You can Zoom.
Thank you. Thank you for that. Okay, we'll take another deep breath. HIPAA, Health Insurance Portability and Accountability Act of 1996. So this has been law since 96. We didn't actually start enforcing it until about 2003. So the Title I is the access, portability, and renewability, which basically means that if you were insurable once, you're insurable now. Okay. The second part of it, Title II, preventing healthcare fraud and abuse, that went into effect pretty quickly, actually, and we started doing things like the Correct Coding Initiative and the Stark laws, and we just had a bunch of things to prevent this, because remember that insurance or medical insurance billing is a new career. It's only been around 40 or 50 years. And so there weren't really any standards. You got paid however you could get paid. We do things like unbundle, so, which is illegal, don't do that. But back in the day, when your grandparents talked about how they charge you for every single aspirin, we did. If we used 4 pieces of gauze to clean your wound, we charged you for 4 pieces of gauze. If we used, and it was called unbundling. So it really became a game with the insurance people, with the billers, between the billers and the insurance. It became a game to see who could get the most money out of the insurance company, if that makes sense. So
my grandma Paula did that because that's what she did for her career, was billing and coding.
it used to be common practice. Now, so with this Title II, with the prevention of healthcare fraud and abuse, what they did is they started to bundle things. So now we have like a global fee. If we do a suture, or if we do a laceration repair with sutures, you get paid one lump sum. We cannot charge for the suture material by the inch. We can't charge for the gauze pads. We can't charge for the ointment. We can't charge for the Band-Aid. You get paid one fee for laceration repair, and that's it. So those global fees are part of this. Another part is with surgeries. Your global surgical fee covers your pre-op visit, your surgery, and your post-op visit. So if you have a hysterectomy, it covers all of that. One fee covers all of your pre-op blood work, the hospitalization for the hysterectomy, and any follow-up care, so that you don't have to pay a copay each time you go in. It's all one fee. Okay. We were supposed to simplify the administrative tasks, which didn't quite happen. So you can see under Title II, we have the administrative simplification broken down into 1, 2, 3, 4, 5, 6 parts, right? We've got privacy, security, EDI, which is the electronic data interface or interchange, which then breaks down to 3 things: transaction, code sets, and identifiers. So I'm not sure that the administrative simplification actually simplified anything, but it clarified things. Okay, so there's a slight difference there. So privacy and security are 2 different things. What I say to you, Larissa, between the 2 of us is private.
Right.
Okay, how we keep that secure is a whole different thing. And so security are things like passwords on your computer, locking your computer when you walk away, making sure that when you're exchanging data with somebody, that they are encrypted and you are encrypted. And it doesn't have to be encryption at the level of federal government and their secrets, but it just means that if you're casually searching the web, you're not going to stumble on somebody else's medical information. Okay. And then electronic data interchange talks about transactions, which would be claims and payments, and then referrals. The code sets, these are things like the ICD-9, the ICD-10, CPT, HCPCS, which we talked a little bit about. UB04 is how we file hospital claims. The ANSI, ASC X12, and that's
It had a thing in the thing that we certified in about what all that meant.
Right.
I didn't write that down, but it had a thing.
It's their
about
secure,
that.
it's to ensure the security of the
Yeah.
information that we're sending. And so that is the standard, that ANSI is the standard that we have to follow. And then the identifiers would be the National Provider ID, that's the NPI, and EIN, which is the Employee Identification Number, which is basically the business's social security number. Okay, it's also their tax ID number. So that's Title II. Oh, and medical liability reform. What it just lays out what we're liable for. Title III are tax-related health provisions. Things like now we can get our we can pay our premiums pre-tax, our health savings account are pre-tax. Okay. Title IV is application and enforcement of group health plan requirements. And then Title V is revenue offsets. So when we talk to somebody out in the community about HIPAA, what do they know about HIPAA? Well, they might know one thing, privacy. Privacy is this much of all of this. Okay, but HIPAA was really, we have privacy, but that's not even in the title of what HIPAA is. Privacy doesn't even make the title. It's all about how we exchange information regarding health status and insurance status, and how we do that safely and securely. That's really what HIPAA is all about. Privacy is this much of that. Hi. No. Okay. Oh, I think I just went through all of those. So the Title I limits exclusions for pre-existing conditions. So you know the Obamacare thing was all about pre-exclusions, right? The Affordable Care Act, we can no longer have pre-existing conditions with the Affordable Care Act. That was one of the big things about the ACA, except that that was already taken care of in HIPAA of 1996. It was just never enforced. That makes sense? A lot of what we're seeing, and when you guys are working on your project, a lot of what we're seeing are the same ideas repackaged and sold differently. So pay attention to that when you are doing your research for your final project. So yeah, pre-existing conditions have already been eliminated, okay? Provides credit for private health coverage. I mentioned that if you were insurable once, you're insurable again by another agency. And it gives us a process for transferring data between the old insurance and the new insurance. So, okay. This allows us to enroll for coverage if you lose health coverage, if you change from group to individual coverage, or if you gain a new dependent. Now, the gaining a new dependent was pretty simple. You had a baby, they let you put it on at any time. You didn't have to wait for open enrollment. But if you decided that you didn't want to be covered by your employer's group health insurance, you wanted to do individual, this allowed you to do that. You were not tied in to the group health insurance. Okay. It prohibits discrimination in enrollment premiums based against the following health status: employees or employees' dependents. So if you had group health insurance through your employer before HIPAA and before it was enforced, if you were obese, you were penalized by your insurance company. You had to pay more. If you were a smoker, you had to pay more. If you were, if you had a family history of breast cancer, you had to pay more. So if you were young and healthy, great, you could have insurance for next to nothing. But if you were in any of their risk pools, they were gouging you. Again, this was repackaged in the Affordable Care Act because while this is law, nobody was enforcing it. Okay, and now it's starting to be enforced. But yeah, depended completely on your, and they called it a risk pool. And so insurance companies would enroll or not enroll based on the risk pool. So if one, say College America, if they looked at the employees on this campus and decided that we were all too fat and out of shape and smokers, they wouldn't offer us insurance. They would, or they would offer it to us at triple the price of somebody else. This guarantees availability of health insurance coverage for small employers. So if you have 20 employees or less, in the past you couldn't. You could, but it was really expensive. Okay. Guarantees renewability of coverage in small and large group markets. Again, if you were insurable once, you're insurable again. Okay. And this does preserve the state's role in regulating health insurance. That's one of the things that's kind of muddy, in that we have all these federal laws, but the states can interpret them and implement them pretty much. They can regulate it however they want. So Colorado's health insurance exchange is completely different from Wyoming's health insurance exchange because it's regulated by the state governments. So there's no standardization. If you were to move from here to Georgia, who knows what their insurance exchange would look like. Fraud, here's the difference between fraud and abuse. Fraud is intentional. You know you are doing wrong. Abuse is unintentional, okay? So fraud is intentional deception or misrepresentation that results in unauthorized payment. This would be things like if somebody came in for a simple visit, established patient for a simple visit, that would be a 99212, pays $80. I'm guessing at that price. But you decide that you're going to charge a 99213, which is a level higher for a new patient. That might add up to only $10. But if you upcode every patient you see that day, that $10 adds up, right? So, but you know you're doing wrong. The doctor said charge a 99212, and you're like, well, if I do this and do that, I can squeeze a 99213 out of it. Okay, that's fraud. If you get hired to do billing and coding and you don't understand how to rate the evaluation and management scale, and you just go, oh, well, I thought it was a 99213. I didn't know any better. That's abuse. Make sense? Okay. So the results of Medicare fraud are criminal, civil, administrative sanctions. Civil fine, $20,000 per false claim plus triple damages. So if you had upcoded 20 patients that day, just upcode them one step, and a lot of people go, oh, nobody's going to notice the difference between a 99212 and a 99213, right? That's the difference of, one extra screening or one extra review of systems. So nobody's going to question that. But if you do that for 20 patients and it's the difference of $10, that's what? $200, right? So you made an extra $200. But civilly, for those 20 patients, you could be fined $20,000 for those patients, which would be what, $400,000 is what you could be fined, plus triple damages of $200, $600. So you could end up owing $400,600 just by upcoding everybody by one step, if they can prove you knew what you were doing. Okay, and that's just the civil fine. That has nothing to do with the jail time. Okay, the criminal fines, imprisonment up to 10 years.
Excuse me.
Thank you. So you can go to jail for 10 years, and you get a criminal penalty fine of up to $100,000. So we were at $400,600, right? And then we add another 100,000, so we're up to $500,600 and 10 years in jail. And then you could still be fined. Okay, so on top of all of that, if you commit Medicare fraud, now you get kicked out of Medicare programs. Now you can't see any more Medicare patients. Okay. And that was for one fictional day. People don't commit fraud for one day. They commit fraud for months and years, and they pocket millions of dollars. It is much more difficult to commit Medicare fraud than it used to be because we have all these checks and balances in place, but there are still people who do it. One of my, it must be, let's see, we've done MED211, we're in MED211 now, so it must be 210 that your project is Medicare fraud. And it's crazy, even with all of these safeguards in place, there's still people who commit fraud. And with all these safeguards in place, if you're committing fraud, you are doing it on purpose. You're looking for loopholes, and that is absolutely intentional. Okay. So examples of fraud can be accepting or soliciting bribes, kickbacks, and rebates, altering claims, that would be my example, billing for services or supplies not provided. There was a big Medicare fraud case in Florida with an HIV clinic where they were working with the patients. So the patients were in on this. So they were billing for treatments the patients weren't receiving, and when they got their checks, they were splitting the checks with the patients. So you can't tell me, oh, that was an accident. That was absolutely intentional, right? Misrepresenting codes to justify payment, entering a health insurance identification number other than the patient's to ensure reimbursement. So say, Sierra, you and I are sisters, and you don't have insurance, but I do. So you take my insurance card to the doctor's office, and they know it's you and not me, but they go ahead and accept my insurance card for you. That's fraud. Okay. And falsifying certificates of medical necessity. Again, anytime you falsify something, you know you're doing it, you're committing fraud.
Sorry, I'm laughing because like I don't know how people do this kind of stuff. Because like right after my baby was born, I went to the store and like I picked up Tylenol because like I was having really bad headaches, and the Tylenol slid under her car seat. And I got all three of my kids loaded into the car and realized the Tylenol had slid under her car seat and I didn't pay for it. And I unloaded all my kids, went back to the store and paid for the Tylenol.
I would,
so like,
right.
it was like $2 for the Tylenol that I went back to the store and paid for it.
Yeah, the guilt would have gotten me. I had to go back too, so I get it. So I totally don't have the mind to do this, but so that was fraud. Abuse would be billing non-covered services as covered services, like you didn't realize, you didn't read the contract, you don't know that what you're billing for is not covered. If you have a billing or claim processing error, if you just type in the wrong number accidentally, but you keep doing that repeatedly without being corrected, that can be abuse. Excessive charges for services, equipment, and supplies. All of this, all of these examples of abuse come down to people not being trained properly. That's all. They don't know, you know. They may not know that the duplicate charges on a claim, they may, because of their training or lack of training, may not know that you can't charge for follow-up care to have sutures removed. That's all part of the laceration repair. They may not know that, okay? So abuse almost always is a lack of training on the part, which is why if you want to do billing and coding, you should be certified, okay, so that you know this stuff. Okay. We're going to go on break before we get into this compliance program. But the compliance program is a great thing because they recognize that most abuse is due to lack of training. So they started this compliance program. Okay. All right, I did email her back. But I was like, no, I checked my email like a good girl. Okay,
Back to the subject at hand.
yes, lovely. All right, so the compliance program, like I said before break, is simply a way for the government to help keep offices in compliance and to offer that training for people who might be committing abuse unintentionally. Okay. These compliance programs help ensure that the claims are true and accurate. If you follow these guidelines, it actually expedites payments because now you have claims that are clean going through. Okay. It does minimize the billing mistakes. And the Stark laws. The Stark laws are the anti-kickback laws. The Stark laws are why we can no longer get drug rep pens. And drug rep pens were my all-time favorite. I still have a handful of them. Drug reps used to come in and they would give you pens and paper and stethoscopes and prescription pads. They would give you all sorts of stuff with their drug name on it, and you could use it. But because of the Stark laws, that's considered a kickback because the physician isn't actually spending money for their office supplies, so they're making a profit from all of these gifts. So they can't do that anymore. Now if drug reps come, they can only bring consumable things, like they can bring chocolates and candies for the office. They can bring lunch for the office, but they can't bring anything like pens, papers. I mean, we had table paper, we had pens. Back in the early 90s, some of the cardiology drug reps were giving away Littman stethoscopes. Right? I mean, $200 stethoscope just for you to consider our drug.
I will definitely consider your drug. What is it?
Right. They used to take entire offices on weekend ski trips in Vail in the late 80s, early 90s. If you will consider our drug. Yeah, they can't do that anymore because that's a self-referral and anti-kickback because the physician's office is making money off of that. Okay. I know, those were the days when fraud was rampant and everybody was making money. But now we can't do that. Now we have problems. I know.
Bring it back.
But, you know, our parents and grandparents actually have a leg to stand on when they would say that you couldn't trust doctors because they were owned by the drug companies. That is no longer the case, but it was the case in the 80s and 90s. It absolutely was. You can't even argue that. But the Stark laws now prevent that mostly from happening. Okay, there's still a few cases out there, but not like it was. Okay. So in order to identify your risk factors, you need to perform audits. You need to do internal audits to make sure that your billing practices are correct. Okay. You need to have practice standards and procedures. You need to train your people, right? You need to have a compliance officer, have training. That's all comes down to training. If somebody accuses your office of fraud or abuse, you can't just say that would never happen. You need to investigate it and make sure that you don't have somebody working for you that doesn't know what they're doing or is knowingly committing fraud. Okay, you really need, because especially if you are the physician in this practice, who is responsible?
You are.
The physician is responsible. So you have to take all these allegations seriously. If you can handle it in your own office before it gets to a government complaint, much better to do that, right? Clean house if you have to, instead of having the government come in and clean house for you and possibly going to jail and paying all these fines. So it really is in everybody's best interest to follow the rules. Yes.
For billing and coding, so we, as a biller and coder, could we audit ourselves just to make sure that we're doing everything properly?
You should, yeah. Or you should at least have the compliance officer should be auditing just randomly, a couple times a month, pull a random chart, check it, make sure that it's been done properly. I say a random chart, a random sample of charts. Say pull 1% of your charts for the month and check to make sure that they've been billed properly. If you do that every month, you're going to catch things. Okay? Unless
And
you,
if
as the
do
compliance
catch
officer, is
something-
crooked.
If you do catch something that you did like on accident or like you added wrong or something, would you be penalized for doing that even though you audited yourself?
So the internal audits are to identify problems and correct them.
Okay.
So the best course of action there would be to document the problem, fix it the best you can, and then hold a remedial training and document that as well. Okay. If you find that you somebody has complained of fraud or abuse, and you investigate it and you go, oh yeah, this person is not doing well or is committing fraud, it's best if you as the office then report it to the correct federal agency and say, look, we did this internal audit. I suspect one of my employees is committing fraud based on the fact that we've had all these trainings and she is repeatedly violating this. It's best if we self-report than wait for the newspapers to show up when the federal government comes. Okay. That way you cannot be accused of hiding anything if you're doing the self-reporting. But if it's just a case of abuse, like somebody wasn't trained well enough, document it, fix it, document the fix, and you're good. Okay? And enforce disciplinary standards. If you have counseled and trained somebody over and over and over again, and they're still not getting it, they gotta go. I mean, this is your entire business at stake. Okay. So some of the risk factors for compliance are the coding and billing. People who don't understand how to properly code to do their billing. Okay. Unreasonable and necessary services, you have to make sure that we're not doing anything above and beyond what is medically necessary. We need to have proper documentation. That comes from the physicians. The physicians have got to document everything properly so that you can, if there's ever a question and a claim that you submit, you can go back to the documentation, pull what the doctor says and submit that and say, see, it does support it. Okay. That can only happen if the physicians are documenting properly. Okay. And then of course you have to be careful of kickbacks, self-referrals, things like that. The doctors cannot own 50% of Merck pharmaceutical and only prescribe Merck products. That's a kickback, right? They're profiting from that. So we talk about medical necessity, and Medicare actually has a program that reviews medical necessity. It makes sure that that the claims or the services are actually reasonable and actually necessary. Okay. What's a MAC? Do you guys remember?
It's
I don't know. I don't care if you know.
Medicare administrative contractors.
So what do they do?
Oh no, I wrote that down too, but I don't remember where.
What do MACs do? I'm glad you know what the abbreviation means, but
I didn't get that. I used switch slide on
okay.
that. Right.
So MACs are the contractors that handle the claims. They look at the claims, see if they are good claims. So they pay or deny the claims. They're contractors that work for CMS.
I was looking for something different. It's right here, but
So
where I read.
contractors that work for CMS.
Yeah, they contract with CMS to review and pay claims, okay,
Unpaid.
and pay claims. If a claim is not payable, then they reject it. But the MACs also audit the claims. And every time they're reviewing a claim is an audit. We don't usually think of it that way, but they're looking for the claim to see if it's correct, medically necessary and reasonable. If it is, then they pay it. If it is not, then they don't. Okay, so that's an informal audit by the MACs. Okay, if they decide to formally normally audit it, now they're going to look at all of the claims and really go through them and say, oh, you know what, this office always screws this up, and they can impose whatever the corrective actions are, the fines or whatever. We have this Medicaid integrity program to fight fraud, waste, and abuse. This one actually came out in 2005, so about 9 years after HIPAA. So HIPAA was supposed to help decrease fraud and abuse, but it was using the correct codes and things were medically necessary, but it, again, like most things in HIPAA, was not enforced. So they made a stricter law in 2005 and added an enforcement piece, which is this Medicaid integrity program. Okay. So MACs audit the claims for overpayments and to provide education about program integrity. So they may not, if they're seeing something that clearly to them looks like abuse and not fraud, they're going to go and educate the office. They're not going to impose sanctions right away. They're going to say, this, we see this as a trend. Somebody obviously doesn't understand something. We don't know if it's the billing supervisor. We don't know if it's one billing person, but something is obviously wrong here. Let's get it fixed before they impose any sanctions. Does that make sense? Okay. The recovery audit program is mandated to correct improper Medicare payments, overpayments or underpayments. I would rather be underpaid by Medicare than overpaid, because once they identify an overpayment, you have to return that money to Medicare. And you can't say, well, you guys paid me. You should have found it. You should have found the error first. You can't get away with that. So I'd rather them way underpay me and then write me a check later once they identified it. And so you can see this is broken down into 4 what they call jurisdictions. They're just 4 areas that the auditor will look at. So again, geographic locations play into this. And because it's our government and they love acronyms, love them, we have HEAT, the Healthcare Fraud Prevention and Enforcement Action Team. It's like CMS's version of SWAT. They want to be as cool as the police, so they have HEAT.
Why is
The
it
enforcement action.
Yes, but it shouldn't be like, it's HCFP.
That's not as cool as calling it HEAT.
Yeah,
Yeah, but it's missing.
It's like missing 3 words that are like important.
Right. It is. They are words that are important. But I'm telling you, I know they have people who just sit in a room and come up with acronyms and names.
I want to do that. Can I have that job?
My stepmom works for the post office, so she works for the government.
Mm-hmm.
And she'll come home and tell us about her day and be like, yeah, and then the AOMPL, and we're like, we don't speak that language, what do you mean?
Right.
She'll just like start talking like that. That's not how the alphabet goes.
Right. Exactly. So, this HEAT is a joint effort between DHHS, so the Department of Health and Human Services, and the Department of Justice to fight healthcare fraud by increasing coordination, enhancing intelligence sharing and training among investigators, agents, prosecutors, analysts, and policymakers. I was not kidding when I said this is their version of the SWAT team. Okay, so this is all the interagency communication that goes on before they have their strike force and shut down an office. I'm so not kidding about this. Okay. Oh, wait, because they have a Medicare strike force team that will go in and seize everything and shut down an office.
But are they like in suits instead of like?
I don't know. I've never actually seen one. I spend way too much time laughing at this slide to actually. They probably look like the Phoebes. They probably look like the FBI when they go in there. You know, their dark suits and
Glasses.
right.
I have a question before I forget.
Yes.
Why isn't test 1 like in the grade book It's like not even there for an option to get a grade. I mean, that was, I don't know, for what?
I noticed that.
Test one is.
I have no idea. It's not all the way at the end in assessments.
It's nowhere.
No.
Huh.
So did I look out? Because
I'm gonna have to go. You guys did it, right?
Yeah.
So I just don't have it activated in the grade book. I'm just gonna have to go publish it for the grade book.
Okay.
Huh.
I thought it was something out of the test.
I don't know why. I'm sorry.
It's not good 'cause it just-
I didn't do a straight job anymore.
Okay, so there's our giggle for the day. Medicare SWAT team, HEAT, with their strike force. I just, I totally see a bunch of little,
They look like lawyers.
don't they? I was picturing like a bunch of nerds in suits with their pencils and yeah, they look like attorneys. Yeah, that's,
Yeah, they look like lawyers.
yeah.
Furious.
Thanks. So the Medicare Shared Savings Program was established to improve quality of care and reduce unnecessary costs. So this is to promote patient care accountability. It requires coordinated care of services, of course, because the coordinated care of services means that we're not repeating things 50 times. Like if we go to Larissa and she runs tests, and then we go to Sierra and she wants to run those same tests, just read these results, unless there's a reason why you think the results might have changed. Okay, so that's coordination of care, okay, and services. This encourages investment in infrastructure and redesigned care processes and, lots of feel-good stuff. Okay. The CCI, I've mentioned the National Correct Coding Initiative. This has different sets of codes, and it helps detect codes that are inappropriate. They look for code pairs for improper coding. So if you report this code, this diagnosis code with this procedure code, it's going to flag it. Okay. Excuse me. So the CCI was to help decrease the fraud and abuse by recognizing certain code pairs that were commonly abused and offering corrective training on that. Okay. This is also part of standardizing how we code everything, because remember, billing and coding is a new career. 40 to 50 years old, everybody was kind of doing their own thing for whichever insurance company. We've only standardized it really in the last 30 years, and with the Correct Coding Initiative, that's even newer, to kind of bring everybody back into a standard nationwide. Oh my gosh, that was all Title I. That was all HIPAA Title I.
No wonder it's really close.
Right? So remember, Title II was the one that had all of those other subtitles under it. And I said it didn't really simplify the administration, but it clarified it. Okay, so it standardized the EDA or EDI, the electronic data interchange. It gives security and confidentiality of health information, and this is the privacy part of it, does establish significant financial penalties for violations. We have the health plan identifier, which each insurance company now has its own health plan identifier. We did not implement the national individual identifier. That's the patient identifier. So we would each have our own, other than our social security number, they would have issued us our own. That anytime the government wants to issue me a number, scares me a little bit. So I'm glad it wasn't implemented, because I already have an individual identifier. It's called my social security number. Right? And then I have a secondary one called my driver's license number. We have the National Provider Identifier, the NPI. This one is kind of a little burr under my saddle because we already had physician ID numbers. but they've changed them all to NPI. So there for a while they made the changeover, on the CMS 1500, we had to report the UPIN, which was the unique physician ID number, along with the NPI until everybody got transitioned over to the NPI. And the reason it's a burr under my saddle is that it's just redundant. We already had the UPIN. Why did we have to reinvent the wheel and give everybody a whole new number? Things like that, to me, are inefficient. And then the EIN, which is the tax number for the employer. So we have the electronic transition standards. Everybody has to use those standards, the EDI. It's how we send from one party to another. It sounds really scary, but as long as you log into your system and you follow the login process and you send it, how it is transmitted, that's all the programmer's problem. We just log in and we send it. Okay, so a lot of the electronic data interchange has to do with how the programs were built. So it's really standards for the people who are writing the code. Thank God it's not me. The thought of staring at all of that code makes me crazy. I don't know how. I have friends who are programmers, and they just look at code, lines and lines of nonsensical words, well, not words, codes, all day long, and they love it. I don't get it. So the data sets, we talked about this for all of the codes, either diagnosis codes, procedure codes, we already have those. PHI, this is what you guys get hammered on a lot, and I think even we talked about this with the HIPAA, the 5-question HIPAA certification, right, last week. The protected health information, we can't give that out. Privacy and confidentiality. So do you know the difference between privacy and confidentiality?
Now that you said that, I don't think so.
Okay, so again, if Larissa and I are talking, what she tells me is private, okay? She has that expectation of privacy. However, if you are my MA, I'm the doc and you're the MA, I have to share some of that information with you. We have to keep that confidential. Nobody else in the room or nobody else on our team needs to know what's going on with Larissa.
Okay, so just the people that are
Directly involved in her care.
Okay, that makes sense.
Okay. So she can tell me something privately, but there are cases when I can't keep it private. I have to keep it confidential so I can go to you and say, hey, let's do this. But I'm not going to announce it to everybody in the clinic that we're going to do that. Okay. Security is the safekeeping of patient information. It's a lot easier with electronic health records than it used to be. We actually, COPIC, which is the big malpractice insurance company for Colorado, COPIC audited our clinic one time, and we got dinged on our security for our medical records because we had big file, we had these big sliding files or sliding shelves that we put our files in. And we got dinged because we didn't have them secure. And we said, but we lock our doors at night. We set the alarm, we lock our doors at night. And he said, yes, but who can come in here when you're not here? We went, oh, the cleaning crew. And they said, bingo, the cleaning crew now has access to all of those patient files. So we had to put up a grate that at the end of the night, we had to pull the grate across so that the cleaning crew didn't have access to the files.
So you know how sometimes doctors like geek out and like they have a patient and something's happening with them and they think it's like super interesting or whatever. So they go and get one of their other doctor friends and they're like, come look at this, even though that doctor's not even involved. Is that like breaking something?
No, as long as it is for a teaching purpose or for a consult.
This looks cool. Like this person has like a.
If they want to show something, then it falls under teaching purpose.
Okay.
If they need information, then it falls under consult. And that happens a lot around here because PVH is a teaching hospital, and Poudre Valley Prenatal is run by residents. Family medicine center is run by residents.
Children's hospital.
That's the teaching
is a
hospital.
teaching hospital.
Yeah.
So
So
we have
you
that
just,
doctors in there
Dental
all the
health is
time.
very obviously a teaching hospital with their ones.
right.
And they were Googling how to do some neck maneuvers on me, and I was like, you should probably leave and do that. Not Google in front of me because that's a little scary.
That is kind of scary. So yeah, if it's
So
something
they
that they
can just-
need information on, then they can go get a consult.
But I don't see how, like, it's like they're just like friends and they're like, dude, come look at this guy's hair. That's cool. Like, how's that?
Because they don't want to freak you out.
They can just like count that as teaching even if they're not really teaching.
Yeah.
Okay.
Yeah.
Interesting.
Now
But it could also be
now
you really
it's
need
been
advice and
part.
They don't want to scare you. So
Yeah,
they
now
do
it's
it.
part of. Now they brought them in as part of their care team.
Okay.
Breach of confidentiality is unauthorized release of patient information to a third party. Most of the time, 99% of the time, breach of confidentiality is something like what you said, where it's just cool, hey, come look at this. That could be construed as a breach of confidentiality, right? But most of the time, it's talking in the elevators, talking in the lunchroom, or this is the easiest way to breach. When you're sitting at your desk, you've got patient rooms over here, right? You've roomed all your patients. You've got a stack of phone calls you have to return. So you get on the phone, you start making phone calls. What is there to do when you're in the patient room as a patient? What is there to do while you're waiting?
Listen.
Right, so then what do?
You listen.
Yes, and you listen. There's so much, you can hear so much stuff when you're sitting in your exam room waiting, okay? So usually breach of confidentiality is completely unintentional and something along those lines where I gotta quick make this call, and you're pretty careful to not give out too much information, but you know, it may happen. Yes.
I went to the urgent care in Good
Uh-huh.
when I got bit by a dog. And then like those walls are like paper thin and stuff. And then like the doctor talks loud, like I'm not gonna be able to hear him or something. But he's not telling me, he's like, you wanna get those shots just to make sure that you don't get rabies or something. And then as I was like, you know, like he was telling me all about his baby shots or whatever. And as I'm walking out, the patient next to me was walking out to me, just like, what kind of dog bit you? That's crazy.
Right.
Just like,
Right. So that's an inadvertent one.
yeah.
Or like when they put you with just like the curtain in between, when
Right.
they're like over full, and so they just have the curtain between the two beds. And a lady told me, please stop crying. Your baby's gonna be okay. When my daughter fell off the bed when she was like
Right.
16 months old and stopped breathing, we had to go by ambulance. She's like, your baby's okay, I promise. And I was like, you okay? She's like, I got into a car accident. I'm like, oh my God, I'm so sorry, I'm crying. She's like, it's okay, will you come here and talk to me? And I was like, yeah.
It's just like,
Just through the curtain. So like a confessional.
And she was like such a sweet lady that it was like okay, and then they put like a guy that was like handcuffed to the bed next to us, and I was like, why is this happening?
Right. So in cases like that, like with urgent care and emergency rooms, you have to make an attempt,
Right.
right?
And they were super nice, and they were like, is this
But it's a
okay
bit
with you?
freaky,
And I'm
right?
like, yes, it's fine. And then like when like the guy came in, like the police officer was like,
Yeah.
I was like, the guy like coming off himself, and I'm like, when are we gonna leave? I just want to go home now.
Right, right. Yeah, you got to be careful about that stuff. And so you have to make an attempt for the confidentiality, and things like urgent cares and emergency rooms. They know that they've got probably 5 people separated by curtains. So when you're working in those situations, you have to be careful not to give out patient information. That's where tell me your last name and date of birth, and the patient provides the information.
And then this one, I've had seen urgent care, 'cause I hate that place, but I go there because if I don't want to go to the ER, I'll go there or whatever.
Mhm.
But like this doctor came in one time, and he seen that I was a girl, and then he asked me my name, and then he's like, "Can you verify your name for me?" And then I told him Glennis Starbucks. okay, I'll be right back. And then you hear him outside and he's like, who's in what room? Because I just walked in expecting a male in that room and it was a female.
Mm-hmm.
And like my chart, like, you know, I don't know, I guess they were on the outside of the doors or
Right,
whatever.
back in the day.
Yeah. And then he walks in and then he's all thinking I was the guy. So I guess the charts were like swapped.
Mm-hmm.
So it always, I don't know.
Yeah, so every time they go in a room, they should verify who they're going to see. And since Devin just spent 3 days in the ICU, I was thrilled to see that every time, even though he had the same nurses, every time they verified before they gave him meds, asked him which meds he was expecting, verified his name, his date of birth.
You probably knew that you knew your shit.
they did, but they do it just as routine, so I was thrilled about that.
Half the time I didn't know if my daughter was even kidding.
Right.
And
Well,
it was, but
yeah.
she was like, they would tell me, if I asked questions, they would tell me. I'm like, okay, what are you giving her? And they'd be like, oh, this. And like, they weren't being like, is this Riley Miller? But like, she was a one nurse patient. So like, her nurse was sitting right there. And it wasn't like they had to come in and be like,
Right,
oh, we just went and saw this person and now we're coming to see.
right.
So
Yeah,
that was
so
a different situation. So
Yeah.
I'm just trying to give a different perspective on it.
Devin's
too.
pretty easy. His meds, potassium.
Right?
That's his meds. How much IV potassium are we getting right now? That's pretty simple.
They had like the tree thing like full of like little machines to give her meds at different times.
So what if they like, when my brother was in the hospital with lupus, they took him out of the room for some tests,
Mhm.
supposedly. When my mom was out of the room and he was just like asleep
Mhm.
or whatever. And then my mom comes back in the room and she's like, where'd he go? Like, she asked like one of the counter nurses like, where the patient, my brother was, or whatever. And they're like, well, they took him for testing. And then my mom's like, they took him at like 5 a.m. to do the same test. Like, why are they doing it again? And then they paged the people that had took him. And then they were like, we didn't know he had already got the same test. So they brought him back to the room. Where does that fall under? Just miscommunication?
Yeah, that's
or-
just, they didn't read the chart to see that it had already been done. That falls under laziness and miscommunication. That's what that falls. Because it's really, I'm willing to bet what happened is they looked and they saw that he was scheduled, but then didn't bother to look to see if he was already done.
That actually happened to me on Saturday.
It happens a lot.
The nurse came in and did my blood work. Like she got all my blood and stuff. And then the guy came in like right as she's finishing up and I was all, she beat you to it. And he goes, what? You already did it? And she's like, yeah, I already did it for you, so you're good. And I'm like,
Yeah.
what just happened? Like,
Long as you didn't get stuck again.
I know. I was like, do I really need some? We might have to pour some more blood. And I was like, no,
You're good.
I think you got it done.
Okay, so the HIPAA privacy rule, this is the one thing that patients know about is privacy. Okay, we know that it protects their individual medical records and protected health information. The violation is up to $100 per person per violation, not to exceed $25,000 per person per year per violation of a single standard. Wow.
What does that mean?
So that means that you, if you were the one violating, they couldn't exceed more than $25,000 per year for you, but it's also per violation. So if you had 10 violations, that'd be $250,000 they could fine you.
Gotcha.
Okay. And they could fine you that every year until you changed your ways.
And they just eventually just go,
Yeah, your
Goodbye.
employer should be like,
I can't do this with
and
you
let me
anymore.
tell you, a HIPAA violation, a HIPAA privacy violation in medicine is the kiss of death. Okay, that is the one thing you can do to completely destroy your career in medicine, is have a HIPAA violation that you get fired for. There is no justifying that. Okay, unless you can prove that you weren't actually in violation, but truly, HIPAA privacy violations, kiss of death for your career. I hope you whatever it is you
I
did
feel like if you
before.
had like 10 violations that got you up to $25,000, ding ding.
Right, then you should be.
I can't do this.
Yeah.
Goodbye.
If it's a minor violation, then they're probably just going to counsel you. But if you're selling information on your celebrity patients to the newspaper, you're done. You're never working in medicine again. Right? There was a whole group of nurses who were fired in New York City for HIPAA violations after George Clooney had a motorcycle accident many, many years ago. They were fired because they all accessed his medical records because nobody would believe that George Clooney was down in the ER. So all these nurses, of course, were looking him up. And they were accessing his medical records, which is a clear violation of HIPAA because those nurses up on the labor deck were not directly involved in his care, were they?
No.
No. He went to bat for them. The hospital administrator straight up fired him. Clooney went to bat for him and said, well, I'm a public figure. I don't have the expectation of privacy. And the hospital administrator said, yes, you do have the expectation of privacy. So I think a couple of them got off with just a suspension. But, man, lots of them got axed right away. And I completely back the hospital administrator in that case, because really, just because somebody is famous doesn't mean that they don't have, yeah.
And I'm sure if the ones that got suspension, it was like, you've been a nurse for like a month.
You know better.
Well, like the ones that got like the suspension, it was like, okay, maybe a month. But like the ones that straight up got fired, it's like, like seriously, come on.
Right.
So what do you do if you're like not treating a patient and then all of a sudden they add you more?
Do you have to do Facebook?
So, and that's actually become fairly common. You could do what I do. I have a professional Facebook page and my personal Facebook page. And I just have to tell y'all, you guys are funny. I can't, because it's my professional Facebook page that you guys friend me on, y'all are funny and I can't like a dang thing. So just know that there's a lot of times I sit in my office and just crack up. And I'm like, can't like that one. It wouldn't be professional. But just so you know, I'm loving your memes. I just can't react to them. Okay?
That's why you just need to make it a fake name.
Right.
That way you can,
Unfortunately, those are discoverable in court. But just so you know, you guys are just, I sit in my office and just laugh. But I can't like it because that wouldn't be professional. Know that I'm thinking of you when I'm scrolling through my Facebook page.
Well, because I used to work for interim healthcare or whatever. I left. And then
your
the girls
patients
I
wanted
used to
you.
take care of added me on Facebook like months later. And I totally forgot that like she was one of my patients that I sent to her. And then she asked me like, how come you stop coming to see me and stuff? And I was like,
Oh, God, that's heartbreaking, isn't it?
yeah, because I don't know, but I'm just like, so what do you do? Like, you just block them or what?
That's a hard one.
Yeah.
That really is a hard one. That's where you might consider a professional Facebook page and a private one. Just know that your professional one has to stay professional.
right.
Don't get the two mixed up.
Yeah, that's scary when you get the two mixed up.
Yeah, I just don't know. So then I'm about to make a professional one and add all the questions.
Yeah.
There you go.
Now I've given you our secrets.
Well, Facebook has like some cool ass features, so everybody's allowed.
Yeah, dial up your privacy on your Facebook page. I think my private one is pretty well locked down. I think you can see my cover photo and my profile picture. Yeah, I keep it pretty well locked down, and not because I don't want you guys to find me, but because I had a stalker, so I locked it down pretty tight then. And then of course my professional one is public because, well, it has to be.
I have specific people
so,
that
yeah.
can't see pictures of my kids.
Yeah, so as far as social media, I would be careful about adding patients unless you have a professional page. And I would follow your employer's policies on that. So did you guys hear about the girl when Black Panther came out, her orthodontist made a post on his Instagram? So like he didn't violate HIPAA by saying, you know, this is what my patient, she's the one who self-identified. So he was not in violation. He just shared, hey, oh my God, I have this patient who, you know, clenched her jaw so much she broke her retainer. And she's the one who self-identified. So he's off the hook on that.
Yeah, which I heard that.
Right. But it's questionable. Yeah, it's questionable that he posted that at all, but I thought it was funny. I would follow him. Huh?
How is that related to Black? I've never seen one.
Oh, so I don't know
She found the guy so attractive
that she clenched
her jaw and busted her retainer.
Yeah, while she was watching the movie.
And the guy,
Right.
the guy actually got in on it. The
orthodontist.
actor,
Oh.
the actor got in on it and said, "I'll buy you a new retainer," because I feel like it's indirectly my fault.
Right. I mean, it turned out great and funny, but it could have gone the other way. And I mean, her orthodontist post was hilarious. I mean, it was hilarious, and it could have stopped there, but she was like, "Oh my God, that's my," and then she linked her friends to it, and then it blew up, and yeah, so then the actor said, "I kind of feel like I should buy your next retainer." Okay. Will you deliver it too? So yeah, just be careful with social media. And that's a really good question, Glynis, actually. HIPAA security rule protects the electronic health information. We've already talked about that. There's nothing new. High tech, back with the acronyms, okay? The High Tech Act just requires that anybody who contracts in healthcare also follow the HIPAA security rule for electronic PHI. So your Xerox guy who comes in and fixes your copiers or fax machines or whatever has to also comply with HIPAA and not release and not talk about anything he may see or hear. That makes sense? Who was I was talking to somebody in the last couple of months who used to work for Xerox, and it is a huge corporate policy that nothing that you come across ever gets discussed or you get fired, even long before HIPAA came in. I kind of want to know what it is Xerox is finding that they make it corporate policy that you never talk about any documents ever, 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 or you get fired. But it makes it easy for them to comply with HIPAA, doesn't it?
Could be that they work on doctor's offices that,
Actually has more to do with politicians.
well, there's that too, but
That's what I think.
it's just there's somebody above them.
Right.
That goes to the opposite.
Right. So part of the High Tech Act is that patients have to authorize health marketing that they receive. And we're actually in the midst of this with 9Health because 9Health has this new program called eHealth Tools that they want to market to people. They cannot do so unless they get a signed waiver from the patient that says, yes, I want more information on this. Yes, you may market to me. This is, I mean, so it's kind of this patients who have to authorize any health marketing kind of ties your hands if you are, and it's a good thing. Can you imagine how buried you would be as a patient if we were allowed to just market all sorts of health stuff to you all the time. I mean, we can generically put stuff up on TV. We can advertise things on TV. But can you imagine what your mailboxes would look like if they could just solicit you all the time?
You have diabetes. Here's all of this information. about
Yes,
diabetes.
and we're the best monitor, and we're the best insulin, and okay, there's only 2 types, but you know, we could do that. Okay. And you cannot sell the protected health information to any business associates or contractors. So your PHI is protected, period. They can't sell lists like telemarketers used to do. We can't sell any of that. We can't say, oh, you were just diagnosed with lupus. I'm going to sell your name to all of the lupus groups so that they can market to you.
Like they used to do.
Kind of, yeah.
How long ago did that change though?
This came into effect with HIPAA, because we're still talking about HIPAA, so 96. But remember, HIPAA, even though we had all these laws, wasn't terribly well enforced, which is why we could repackage it as the Affordable Care Act and sell it again.
And this is talking about drugs, you said?
This is talking about any health marketing. Yeah. So, all right, let's go on break. And I will pause this. Okay, sorry about the delay. I went back to check my emails and had 23 new emails. Yeah, if I don't check every hour, I can't even imagine what it would be like. Yeah.
I find it actually stop emails from certain places, like, because I would sign up for these, like,
Oh,
job
right.
seek and, like,
Right.
Indeed.com and whatever, and so they would send me, like, thousands of emails, and so I finally figured out how to scroll down and click not to get those anymore.
I know, I love the unsubscribe, but it's for my other job that I'm checking my emails. Okay, so I apologize for leaving you guys hanging. We talked about, just because it's projecting on there doesn't mean it's projecting here, right?
Maybe it's blank. So.
Right. It says it's over here. It doesn't say it's up there yet. Yep, that's exactly how I feel. But we'll get through this, and then we will all say that you have had HIPAA training other than the privacy portion of it, that you understand the rest of it.
So with these little certificates that we've gotten, can we list those on our resume? when
Yes.
we apply?
Yes.
Will that count as experience in working with the system? Because there's some, like, let's say like Banner or whatever has an opening for field department. Can we list that?
You could
that
list
maybe
it.
they'll consider?
You can't list it as experience, but you can list it as education and training. So there should be a thing for education and training, and you can list them under there.
If you don't if you don't pass the, like, I'm not saying the final MA, like.
Oh, yeah, your certification test?
Then do you still get the associate's degree?
Yes. The degree is not dependent at all on your certification.
Okay. Because I don't even think I'm gonna need, because I could take it sometime, even if I don't take it right when I end school, I can still have.
So we have some grads who are in a really bad place right now because they didn't take it when they about the time they graduated. So if you wait more than 5 years from the time you graduate to the time you take the test, you have to jump through a whole bunch more hoops.
Just because I don't plan on being an MA or anything like that.
What are you gonna do when you grow up?
I'm gonna work.
Oh.
I'll be in work.
What do you want
Right.
just to call it?
So your MED211 class is your test, your certification prep class. So you can, you might as well just go get a certification so you have something to fall back on. But yeah, you want to be a deaner, right? Do that.
I don't know if that's anything for it.
Yeah, the deaner's the
Well,
autopsy
it's-
assistant.
Yeah.
Yeah, preps the autopsy and assists.
Like the medical system.
I wonder if there is a deaner certification. I don't know. I think it's always good to have one in case something changes in the future. But if you wait more than 5 years from the time you graduate to the time you sit for your certification, it's 50-50 as to whether or not you can get certified. Okay, so I've got a couple of grads now who are coming back in auditing classes, trying to refresh their skills so that they can sit for their certification again, because they didn't do it when they graduated. So yeah, your degree is not at all dependent on your certifications. Okay? So we're back to high tech. Permits compound authorizations for research, information of person deceased more than 50 years is no longer considered protected health information. How long is a generation? 20 years?
I think it depends
Like
generation to generation how long it actually is.
Right. But, I mean, so this is a long time. 50 years after somebody dies, now their information's no longer protected. Okay, in 50 years, who's going to care? Unless you're a celebrity, right? This does allow disclosure of the decedent's PHI to family members or others involved in care or for payment of care, which is good because, like, my grandma just died in February. If this wasn't in place, then my mom wouldn't be able to file for any of the life insurance. She wouldn't be allowed to make, the health insurance payments or receive payments from them. So this part is a good thing, that family members can have the PHI in order to close out. I don't want to say close out the business, but do the business portion of death, because there's a lot of business portion of death.
But like your records can be destroyed 2 years after you die.
Yes.
So
there's no PHI to release, really, right?
Right, if they did destroy it. So that's really
right.
I mean, it makes sense because if they didn't destroy it. But
yeah, it's kind of
once
a
a
catch.
person dies, is information about them like say like the cause of death or something like that, is that protected?
No.
'Cause it's not
Under the
public.
Open Records Act, it's not. So that can be released.
So you can
But
just go
if they
down.
were HIV positive, that cannot be.
So it has to be something that had to do with actually their death.
Yes.
Anything in their real life.
And most of the time they don't report. I mean, the only time they ever report out cause and manner of death is in criminal cases or suspicious homicide cases. That's about the only time they ever do it. Like, they're not going to release cause and manner of death to the public about my grandma, because why would it matter if she was 89 years old and had congestive heart failure, right? So
I ask questions like this because we don't know a lot about my husband's parents.
Mm-hmm.
Like, we know his maternal side, but we don't know anything about his paternal side. His dad passed away in a farming accident 2 months before he was born.
Oh, wow.
And there was a lot of discontent between the families.
Right, so a lot of stuff
So
is
we
held
don't
close to the
know-
vest. And
We don't know any health information on that side to look out
Right.
for our children.
Right.
So it was just something that was oh, that'd be kind of cool. We're in contact now with families, so if we did
So it works out.
that, it would be nice.
Yeah.
To know, but.
so patients can restrict health plan access to medical records when the patient pays out of pocket. So if you go to this new clinic, it's somewhere in the Fort Collins, Loveland area, that is a cash and carry clinic. They don't bill insurances. They don't have contract with insurances. If you go there and pay cash out of pocket, you don't have to tell anything to your insurance company because the contract isn't with the doctor and the insurance company. Okay. And patients have to have access to PHI. Remember, you guys, I was complaining about Banner and I couldn't ever get their system. They finally had a thing at my doctor's office that said patients can now self-enroll. Hey, and their self-enrollment process was super, super easy, not that convoluted process where they had to set up your username and password in the past.
They enrolled me with my son, and I don't know any of the information.
Right.
When I had my son, they were like, "Here, let's enroll you in this," and I'm like,
Okay, and that's where I
Now
kept
you
running
don't
into
have
it. But now you can self-enroll into Banner, and now you know, which is nice. So the patient has to have access to their electronic PHI. Okay. This does allow us to release or allow proof of immunization to be released without a release of records. So you guys all had to get your immunization records. Okay. If for some reason you were having trouble with it, we could, under this High-Tech Act, contact the school and say, in order for them to be admitted to our school, they must show immunization records. That's not a requirement for admittance to our school, so it doesn't really work that way. And just to be on the safe side, we have you guys sign a release of records for your immunizations. We either say get them yourself and bring them to us, or if they're out of state, we'll say, here, sign this release of records, we'll fax it over, and then they'll get it to us, just to CYA. Okay, we want to make sure that we're not in violation, even though according to this, we could do it. It's not difficult to say, here, sign this release of records, and that way we're covered, right? This also provides recipients of fundraising communication with opportunity to opt out of receiving communication. So if you somehow get on the mailing list for MS or multiple or muscular dystrophy, you can opt out of that. Okay. It did revise the Genetic Information Non-Discrimination Act, which is good because if you had done any sort of gene testing before, you could be put in this database, and then they could say, oh, you know what? You carry the BRCA gene. We don't have to, we don't want to cover you. Do you guys know what the BRCA gene is? The breast cancer gene? Okay. And then what most people are familiar with is the Notice of Privacy Practices. Okay. The ROIs, it's just a release that says, yep, you can give this person my information. There is an exception to the release of information, and that is if it's for continuity of care. So if you were to come into, and we've had this happen, when I worked at the family practice, we had a kid break his leg, come into the ER, come into our office instead of the ER. We took x-rays and went, holy crap, we can't fix this. A cast isn't gonna fix this. They have to go to an orthopod. I didn't have to have his parents sign a release of records because the orthopod is now part of the care team. So I could send his records pertaining to his fractured leg, and I could send his x-rays over to the orthopedist without a release of information. That's the only exception, is when it's part of the continuity of care thing. Now, did I have to send over there that he was on acne medication? No, that has nothing to do with the fact that he's got this incredible spiral fracture of his leg, and it was incredible. It was the coolest x-ray I've ever seen. But I could send that over without a release of information legally, because now we've just brought them in, and under confidentiality, anybody on the care team has access to information, right? Okay. We have to keep track of a release of information. We need to know who's been, which information has been released, and who authorized the release. And if somebody sends a release of information, you have 60 days to comply with that ROI. Okay. We've talked about the tax-related health provisions, that we have all of these pre-taxed things we can do now. So your insurance that comes out of your check is pre-taxed. Your health savings account is pre-taxed. I'm trying to speed up through this because I'm tired of HIPAA. Are you guys tired of HIPAA? Mm-hmm. Okay. So we have state insurance pools. We've got the IRA distributions to unemployed. So if you become unemployed, how do we distribute your monies back to you? Under this, though, we have the organ and tissue donation information included with income tax refund payments. It's not that they are saying, hey, you're a tissue donor, but when you get your refund back, you should see something in there about organ and tissue donation. Can you get paid for that?
No.
No. However, right. However, they can cover your medical costs. So if you're going to donate a kidney to somebody, then the insurance will pay for the surgery and the follow-up care. but you're not going to get paid. They're not buying your kidney.
What all can you donate without dying? Just the kidney?
Parts of your liver, your kidney,
Or really, well, like,
skin.
Yeah.
Yeah.
Well, that's not bone.
What?
Well, it's tissue though, isn't it? We are bone marrow.
Yes. Bone marrow is a big one.
But you have to be in a certain health and weight category. And I think age
Right.
also plays a factor in bone marrow.
Right. So yeah, bone marrow is a big one and a huge one. Bone marrow is a great thing to donate if you can do it. If they can find a match, then you can do it. I have heard it's
I
excruciating.
was gonna say, how does that work?
They do a needle aspiration into your hip, and they just suck it out. But I have heard, I'm not a bone marrow person. Yes.
Then I got
Hmm?
then I got that one.
You got a bone marrow transplant?
Yeah, because I guess that one is this one.
Uh-huh. Or did they just do a bone graft, which is slightly different than bone marrow?
How do they do that?
The bone graft is typically surgical. So, whereas the bone marrow is, they drill down into the bone
Is it like
and
a
insert it.
huge needle?
Huh? Yes. Yes. I've heard people who've gone through it said it's absolutely excruciating, but the best thing they've ever done because they can help somebody with like leukemia. They do a bone marrow transplant. I'm all about organ transplants. I've been an organ donor forever and ever and ever. But I want to be dead when they take my organs. I'm selfish that way. I want to keep the ones I have. And then when I die, you can have anything you want.
That's what I said. I'm like, I want to be cremated anyway, so it's not like I need anything.
That's what I tell my kids. Take what you need, burn the rest. That's the way it's going to be for me.
After we're done with this, if you know anything to tell us about
Yes, donating eggs. Okay. I know very little about it, but I know enough, I think. Okay, Title IV, HIPAA, Application and Enforcement of Group Health Plan Requirements. Did you see, so Title II was, how many slides was Title II?
Like, a million.
Like 20? Okay. Title IV, the Application and Enforcement of Group Health Plans, 1 slide, 2 bullet points. So you can see where most of the focus of HIPAA has been. Okay, it's been in Title I and Title II. Everything else has been much less. Okay, so this is just enforcing your group health plans. Okay, these are the requirements set forth. Now we're going to enforce them, is what they said in HIPAA. When did they get enforced? ACA. Okay, so they've been sitting on the books. That's one of my, this is my opinion. It's one of my biggest beefs with our government is they put out laws, but they don't ever enforce the laws. So then we want new laws, but let's just enforce those laws.
Let's just
Like HIPAA's always,
God.
HIPAA's been around since 96. What is that, 21 years, 22 years? Why didn't we just enforce it?
Depending what month they.
Right, right. So that's just my own personal thing that makes me crazy because I am a rule follower by God. If it's a rule, everyone should follow it. Sometimes it even works out that way. So Title IV, Application and Enforcement of Group Health Plan Requirements. They set forth the requirements. They're going to enforce it. Clarification of continuation of coverage requirements. Like if, Glynis, you lose your job and you want to go on COBRA, this protects you so that you can go on COBRA, which is like a gap insurance between jobs.
COBRA costs you a lot of money.
COBRA is excruciatingly expensive. I know patients.
You're unemployed.
Yeah,
You get a lot of money.
I know patients who said their COBRA payments were more than their mortgage. But they had to do it because they were on so many medications or under so much care that they had to have insurance. So, and then Title V are the revenue offsets. So if the company owns their own life insurance, then they get credits. If individuals lose U.S. citizenship, how do you even lose your U.S. citizenship? Not that they renounced it, but that they lose it. How often do you suppose that happens? Then we can recoup money. Right, right. I mean, don't you have to like commit treason for that to happen?
Something.
I don't know. I think I learned it in civics class in 7th grade, but I don't know that are you looking that up?
Yeah.
Okay. And then, so this is just to offset any, or to balance expenditures and profits. So how do we lose it?
Nope.
There are so many answers to this question.
Really?
Most of them are revoking. That's how they lose it.
What is
Most of
that?
them are revoking. That they choose to give it up. They say, I want to be a U.S. citizen.
But that's not losing it. That's giving
It's
it up.
revoking it, but it's still technically.
Like, I want to be a citizen of Mars. That's
But
not
you
losing
can't.
it.
But you can't lose your citizenship just by living outside of the United States for a long
Right.
time.
Right.
So like
you're
I
still
can
a
move to
US
Canada
citizen.
and live there for 20 years, but I'm still a U.S.
So how do
citizen
you
because I didn't say.
lose it? Because that's
I don't know.
giving it up.
Hold on, there's a list. There's billions.
There's another paragraph.
There is.
two.
I'm trying to decide what we're going to do. I just need to see what this one is and see if I can do something other than. Time is at 11. You know what I'm going to do? Because I'm done with PowerPoints. I'm sure you guys are done with PowerPoints, right?
Yes.
I'm going to give you guys time to work on the homework, which I know, Sonia, you've already got chapter 5 done, but you can work on let's just work on some homework and save the other riveting PowerPoints for Thursday. I know, something to look forward to. But first, what question did you have about egg donations?
What do you know about?
Um,
I want to have 2 more cans and then donating.
there is a fairly strict age limit to donating outside. So like you can auto donate or you can donate to,
A certain percent.
yeah. So my best friend, and the only reason I even have any knowledge of it is that my best friend and her wife donated, so they have their own kids, but her wife had to donate the eggs for that to happen. So if you wanted to just donate them to a bank, you have very strict like age, and there's a whole bunch of strict limits. Right. But within your family, it's slightly different. So she had to, my best friend's wife had to sign away her rights, her parental rights, so that she could donate the eggs. So if you donate your eggs, you have no rights to the children.
Mm-hmm.
Which is really weird considering it was in the marriage, right? So she had to sign away her rights to her children after they were born, then she had to petition to adopt them, even though they were her own genetic material. But that was because before same-sex marriages, we didn't have this whole wrinkle in it. You could just donate eggs elsewhere. There's a lot of hormone shots involved because normally when we ovulate 1 egg at a time. But in order to harvest eggs, we want multiples. There's a lot of hormone shots involved so that multiple eggs ripen, is that the right word, are ready at the same time so that they can harvest them. And they can harvest them transvaginally. So they'll go up into the vagina and then out through the wall to the ovary. Yeah, and then they'll take them out that way. I don't know what the payments, because of them, they paid for it, well, of course, with their insurance, but she wasn't reimbursed for it. So I don't know what the reimbursement is for that. So I know that the hormone side and the retrieval side, I don't know the legal side other than you sign away your rights.
Last time I looked into it, I thought it was like 30,000 per egg.
Yeah, I know that it's pretty pricey if you can go through it. Plus, they cover your medical care.
Right, and you can't be like on birth control or have sex.
Right, because they want it all. They want all of the eggs they can harvest. It's kind of a cool thing, in all honesty. Who would have thought to do that?
Well, something's got to pay for college.
Right.
Yeah, like, let's go.
Right. I thought about it when I was younger, and then I you know me and needles. I was like, oh, I have to give myself hormone injections every day.
That
Nope.
doesn't.
Yeah, you don't mind needles at all. You're awesome.
So that's
I hate them.
I want to have a child in the next 2 years,
Mm-hmm.
and then if it's not a boy, I'm trying to get,
Mm-hmm.
you know, and if that's not a boy, then we're done. But you know what I mean?
Right.
Then I just want to like donate a few eggs, you know.
Right. Right. Yeah. I don't. Kind of a cool idea. I thought about the egg donation and then I went, no, but I do pregnancy really well, so I would be a surrogate.
See, and that's what I was thinking too. But then again,
Hi.
Can I shoot your class? Film your class, so.
I was like, well, it's not much interesting, but absolutely you can come film us.
Okay, just for a few minutes.
Sure. Sure.
Awesome. Cool.
I'll tell you.
Do you want lights on or off?
7 on.
Is it all or nothing?
Yeah,
It is.
it is all or nothing.
No, I'll deal with what I have.
Okay. All right. So we were just talking about harvesting eggs. It doesn't matter what we're talking about as long as we're talking,
I
right?
have no audio, it's just pictures,
Okay.
and I won't shoot you egg harvesting on the pictures.
Okay, good. All right, so this is, I guess, a good time for random questions.
Well, I came up with the answers though for that.
Oh, okay, give us our answers.
So there's 7 ways, and this is a doc-up. So
Okay,
I'm
right,
gonna say that it's
So
pretty
it's-
legit.
right. It came from the government. How do you lose your citizenship?
Obtaining naturalization in a foreign state after the age of 18. Taking an oath, affirmation, or other formal declaration of allegiance to a foreign state or its political subdivision after the age of 18. Entering or serving in the armed forces of a foreign state engaged in hostilities against the United States or serving as a commissioned or non-commissioned officer in the armed forces of a foreign state.
That makes sense.
That makes perfect sense. Yeah.
Accepting employment with a foreign government after the age of 18 if A, one has the nationality of the foreign state, or B, an oath or declaration of allegiance is required in accepting the position.
So you're kind of renouncing. Okay.
Yeah. Formally renouncing U.S. nationality before a U.S. diplomatic or consular, I don't know that word, so I'm just going to leave it where it was, officer outside the United States. Formally renouncing U.S. nationality within the United States, the Department of Homeland Security is responsible for implementing this section of the law, and any inquiries should be directed to DHS. Or conviction for an act of treason against the government of the United States, or for attempting by force to overthrow or bear arms against the government of the United States.
Those make sense. Yeah. All right. All right, Veronica, what was your question?
How does one get an enlarged liver?
Oh.
Now we're talking about liver.
Yep. So it can be because of an inflammation. So it could be something like hepatitis A, which is a communicable disease.
Tell me that.
Oh, hepatitis A is acute, so it goes away. So it's a,
I've been vaccinated for hepatitis A and B.
okay. It can be, yeah, it can be any sort of inflammation that would enlarge it.
So it's reversible.
Can be. It just depends until you get your test results
So-
back. We have no idea.
So I have to do a procedure.
Uh-huh.
To go see a gastroenterologist.
Gastroenterologist.
Yep, that's the one.
A GI doc.
Yep, that one. And she told me on the phone that she was going to put my information in the system and that I was going to have a procedure. No one said anything about a procedure. They just said, follow up with this doctor. So I'm a little freaked out and I'm
Right.
stressed and I'm worried and I feel like I'm going to have a heart attack.
Well, don't have a heart attack because it really, enlarged liver can be anything. It could be temporary, it could be chronic.
It's like, it's painful. Like,
Right.
I-
So if it's painful, then it's probably inflamed for some reason. So I don't know what it is. Would you like us to get out the bones and actually do something besides
No.
sit and talk?
No,
Okay.
it's
People are going to look at this and go, oh,
no,
man, she's
I've
talking
got-
about insurance.
I've got so many shots like that,
Okay.
seriously.
Perfect.
It's mostly, sorry about faces, but I do want to see some people from Fort Collins rather than Colorado Springs.
or Salt Lake? Got
Or
it.
Salt Lake, exactly.
Okay.
Yeah.
So yeah, I don't know. Do you have any of your test results or anything?
I don't, I mean, I do, I have all the labs that they get at the ER.
Mm-hmm.
And they did a
A hip panel. Uh-huh. Hepatic.
hepatic, that's it.
They did a hepatic
I
panel.
have the word in my head,
You bet.
I can't, but I'm just like, I don't.
You just freaked out till you talked to the GI doc.
And then they also said that I'm overstressed.
And they helped your stress by adding more to it.
Yeah, and then it said on the paper, like the pancreatic tail, or pancreatic tail is, it's like this weird word that I've never seen before. So basically, like there's a like gas valve or something. I don't know what that means. So like part of the tail of my pancreas is not okay either.
Right.
So, but back in July, I did an endoscopy,
Mm-hmm.
and they didn't find anything. They didn't find anything wrong with my gallbladder, but then it said something about a hepatic cellular disease or something.
Mm-hmm.
And when I looked it up, they said that it was cancer. I was like, okay, let's not go that far.
Right.
Because I
Just understand. Right. Just understand that most of the time, things like that, they always give you worst case scenarios. So try your best to relax
Like,
until you get to the GI doc.
About this enlarged liver, or like, is this something that's seriously? And then it was like, hepatic cellular disease is rare, and 1 in like 5 million people can get it. And I was like, I'm one of those ones. I'm all
If
starting
you
to
are, buy a
cry.
lotto ticket.
Huh?
I said, if you are 1 in 5 million, get a lottery ticket,
Seriously?
right?
I don't know.
Yeah.
She just freaked me out. I'm like, you should be fired. Like, you should not. She's like, well, we'll do some blood work and then we'll do your procedure. And I'm like, what are you talking about?
Right. So
Nobody-
this is actually good. This is actually good because our job as MAs is patient education, right?
And to not scare
So-
them.
Right.
We're supposed to calm them.
Right. We can
can
still give them scary information in a not scary manner. Right?
So I called her at 4:45, and it was like, your estimated wait time is 1 minute. I was literally on the phone for 5 minutes. And then she answered and talked really, really fast. And I was like, I was in the hospital on Saturday. I was referred to you by Dr. So-and-so, who did not sign my prescription for Tramadol, by the way.
Right.
So I don't have that pain med. I'm self-medicating. And it's sucks.
And what are you self-medicating with? Please don't say
Aleve.
Tylenol. Okay. Because
Yes.
yeah, you don't want Tylenol on it. No,
It
it's
says-
with-
Tylenol, bad.
It says naproxen
uh-huh.
or
Naproxen sodium. Or, mhm.
sedative or whatever that it's coated with it. I don't know. The tablet is 220 milligrams.
Okay.
So I'm taking 3 of them every 4 to 6 hours as needed for pain. But I'm really trying to stay away from it because Nate said to stay away from Aleve.
Yeah, any of those anti-inflammatories can actually increase inflammation in your liver a little bit.
Like,
But it's because your liver's job, the reason it can increase inflammation is because inflammation is because your liver's job is to filter out toxins,
And then
and that is a toxin,
it's like, what the heck?
right?
Yeah.
So that's why it can increase.
like ever since Saturday, every morning, because I sleep on my stomach and I sleep on my side, I toss and turn all night. But I literally feel like someone like karate chops me in the stomach every morning. Like, you know how like your kids are like, Mom, Pop, you know?
Right.
Seriously, that is how I feel every morning, and I'm just like,
Right.
I'm in
Well,
so much
hopefully-
pain, and
Hopefully the GI doc will have some answers for you and will
in the meantime,
put your mind at ease.
In the meantime, though, I work at an assisted living and memory care, and I get a lot of calls, and a lot of times I'm by myself.
Right. So now you're
So-
lifting as well.
Yeah. And last night, I wasn't even supposed to be working last night, but I got called in, and I ended up, 2 girls were chit-chatting about personal stuff. And I'm like sitting here with the patient going,
Help would be nice.
hello, he's
Right.
obviously entertained, but can we put him into bed now? Because that would be great.
Right.
And he's very stiff. And so I'm like, I guess I'm doing this by myself. So I lifted his feet. And I was like, there you go. I was like, that didn't feel too great.
Yeah. Sorry.
But I'm just freaked out. I'm scared. I'm holding it together, but I'm scared.
It's okay to be scared till you find out what's going on. But like I said,
I hate her, the doctor.
Right.
Nurse lady. I was like,
it's a good opportunity for us to remember to never treat anybody that way. And we should always make sure that we have time to answer questions, even if you're rushed and you can't answer the question right now, it's not that hard to say, you know what?
Instead of just throwing something out there.
I'll touch base with you here in a little bit because I know you're processing a lot. So I'll touch base with you tonight or tomorrow morning.
And then they gave me all my labs and stuff, and I sent it to Kayla, and I'm like, what does all this mean?
Mm-hmm.
Because I have numbers thrown at me, I'm negative for this, and then one of them said positive, and then it said negative. So I'm like, is it negative or is it positive? Like, because it says vary, and then it says result or something switched. And so like one's positive and one's negative, and I'm like, I don't even know what that is.
Right.
I'm all, where's my medical journal?
Hopefully your GI doc will have some better customer service for you.
Yeah, seriously, because I want to throw a country.
Right, I hear you. Okay, so we're going to go, I'm going to end my recording and we'll spend the last hour